Hey friends, I have a special bonus episode for you today. I recently had the chance to join my friend Nurse Gwenny on her podcast, where we talked through two rapid response cases that never should have happened. These were patients who were showing clear signs of deterioration long before the rapid response team was ever activated. And we break down the clues that were missed, what could have been done differently, and lessons we can take back to the bedside. So if you don't already listen to Nurse Gwenny's podcast, do yourself a favor and go subscribe. I absolutely adore Gwenny. She's one of my favorite people. If you enjoy my style of teaching, I can almost guarantee you will love hers too. We are both passionate about equipping nurses with the knowledge and confidence to respond to emergencies. We are both patho nerds who read scientific literature for fun. She's incredibly knowledgeable, a great communicator, and so much funnier than me. Gwenny was kind enough to let me share the audio from our conversation with all of you. So after you listen, be sure to check out her podcast and show her some love. All right, enough for me. Let's jump into the episode. It's easy to get caught up in the task, but if we can just take a moment to look past the task and see the human in front of us and say, okay, what's happening with them? How can I promote their best outcome? Are there any changes that I need to be speaking up and saying something about to advocate for what their needs are? How can I do that for this patient?
Welcome to the Nurse Gwenny Podcast, where we talk real-life, high-acuity, evidence-based care for the trauma bay, the truck, and the aircraft. Before we jump in, a quick but super important disclaimer. This podcast is for educational and informational purposes only. Always practice within your own scope, certification level, and local protocols. Follow your state regulations, your medical director's guidance, and your facility policies. The views and opinions expressed by me and any guests are our own and do not represent the views of our employers, affiliates, or organizations. While we make every effort to reference current evidence-based literature and provide accurate, up-to-date information, we are human. Medicine evolves, guidelines change. It is your responsibility to verify information, review primary resources, and apply clinical judgment to your own patient population. Now, if you're loving this content and want to get continuing education for it, head on over to the Nurse Gwenny Library, my online educational platform where you can access long-form content, including my comprehensive critical care transport course, Flight Ready. If you're going to listen anyway, you might as well get CE for it. You can find everything at library.nursegwenny.com. And finally, this content is copyrighted by Nurse Gwenny LLC. And while sharing is caring, reproducing without written permission is not. This podcast may not be reproduced, redistributed, or repurposed without written consent. All right, enough yapping. Let's jump in.
All right, welcome back to another episode of the Nurse Gwenny Podcast, and I'm 100% sure you guys are all going to recognize the voice of today's guest, the rapid response nurse, Sarah Lorenzini.
Good morning.
Thank you so much for coming on the podcast. So as you guys know, Sarah is a rapid response nurse. She has a podcast where she does top-notch education. She's also in the Nurse Gwenny Library. So if you're already listening to her podcasts and you want to get CEs for it, continuing education credits, come listen in the Nurse Gwenny Library where you can get CEUs for it. So today, Sarah and I are going to be talking about rapid response calls that never should have happened. So Sarah, start us out. What constitutes a rapid response call that never should have happened?
Sure. So I'll backwards a little bit. Rapid response is when there's an emergency happening on the inpatient side. So a patient's admitted to the hospital. We don't expect them to have an emergency erupt, but they have gotten sicker for whatever reason. And the bedside nurse is kind of like calling in the reinforcements to help with their patient who is deteriorating. Okay. So rapid response that should have never happened are patients who are giving us those warning signs that they were deteriorating hours and hours and hours ago, and no one was picking up on it. Or even worse, the nurse was picking up on it and they were trying to advocate and no one was hearing their concerns. And so that's what we're talking about today is rapid responses that should never happen because patients do get sicker, but we want to catch it before they're in shock.
Yeah, so the rapid response team is kind of like EMS for inside the hospital. So help preempt us with what kind of experience does somebody have to have? Does a nurse have to be on the rapid response team?
I can't speak for every hospital, but generally speaking, some sort of critical care experience. So ER nursing, ICU nursing, definitely like ACLS certification. A lot of hospitals require certification in your specialty, so like CCRN or CEN. But that critical experience, I think, is the most important. As a new grad, I was wholly unprepared to respond to deteriorating patients on the inpatient side. You're seen as the resource for the whole hospital. You kind of got to know your stuff.
Yeah, awesome. Sounds good. And you run the rapid response team at your hospital, right?
I do. I'm the supervisor of the team. I actually started the team at my hospital prior to having a dedicated team if there was an emergency, say on the 7th floor, the ICU charge nurse would leave the ICU and go respond to the emergency and then have to go back to their unit. But since I've started our dedicated team, we're a team of nurses who all we do all day long is both respond to and prevent emergencies. So there's no need to pull me away from another patient. That is what I'm supposed to be doing, is responding to emergencies and nothing else.
And you don't just respond to emergencies, but you preemptively make rounds on all of the units, and you're preventing some of these emergencies, right?
We sure try our hardest. I'll be honest with Gwenny, some days the volume of emergencies is so high, I haven't even had time to do that proactive work. Like yesterday, for example, we pulled what we call the MUSE, Modified Early Warning Score, at 8 a.m. And we found a patient to go kind of take a look at and get some things going to prevent emergencies. But then after that, it was rapid response, code blue, stroke alert, rapid response, code blue. Like, it was so busy, I didn't get to do anything proactive the entire rest of the day because it was just responding all day long. So as much as I love preventing emergencies, sometimes, there's only so many rapid response nurses to go around. Yeah, just putting out fires all day long. And so, in fact, one of the cases I wanted to talk about today is a patient that I probably could have caught with the MUSE had I been able to see it in the morning, but it was just a busy shift that we were already responding to emergencies, and we didn't catch the patient until the afternoon MUSE pull. So yes, I love proactive work, but honestly, proactive work can be done by the bedside nurse too, not just by a rapid response nurse.
Yeah. But one thing we have to remember is that, so in the hospital, I've only ever done ER. I've never done ICU, med-surg, telemetry, any of those other specialties. And so I'm used to generally just having 3 patients at a time. But I know that our colleagues who work on med-surg or maybe some of those lesser acuity floors, they might have 6, 7, 8 patients at a time. And if you divide that out in an hour, at max, they're spending a few minutes of each hour with every patient. And that's if all they're doing is going from room to room to room. That doesn't give them time to go to the nurse's station and chart, or heaven forbid, take a lunch break, right? And so it can be understandable that if a patient is rapidly deteriorating, it might not be caught until the next time that nurse is able to get into the room. So I know your heart, Sarah, and I know that anybody who's listened to your podcast knows you, but for anybody who's not familiar with you, I do want to set the stage. We're not here today to tisk on any nurses who may have missed some signs. We know that you can only be in one place at a time, and that sometimes when patients crump, they go quick, right?
For sure. And when you're working med-surg, it is a lot of team nursing. And so maybe it was the nurse tech or CNA who took the vital signs. They hadn't even told you that your patient's vital signs are terrible. You're just going on your merry way, passing medication to other people, wholly unaware that your patient has declined. And so, yeah, definitely want to give some grace that it's impossible to be everywhere at one time. I want to say, too, I was maybe 10 or 12 years into nursing when I started as a nursing professor teaching clinicals. And I had this realization, like, oh my God, I've never worked med-surg. I'm teaching med-surg clinicals in 3 weeks. Like, I got hired for the job and it didn't occur to me I'd only ever worked ER and CVICU. And so I called my friend who was the director of a med-surg floor and said, hey, can I pick up shifts on your floor just to practice med-surg nursing to make sure I can speak to you at the challenges? And she laughed at me like, Sarah, you've never had 6 patients at one time in your life. I was like, but these are stable patients. Like, I'll be fine. I was not fine, Gwenny. I was not fine. I was so overwhelmed. There were so many tasks to be done, so much going on. All my meds were late. I didn't finish charting until 2 p.m. I was behind the entire time because it's hard to juggle 6 patients, let alone remember their names and their diagnoses. So when I come to a nurse and say, tell me about your patient, they're like, hold on, let me pull up my paper. I get it. I totally get it. 6 patients is so much to keep track of. Yeah, just want to start with the grace. So the cases we're talking about, yes, things could have gone better, but I also understand the challenge of having 6 patients. I think I did 4 shifts total med-surg. I was like, oh my God, I'm not organized enough for this. I don't think I can do this.
I need to go back where I can thrive with my ADHD, and that is the emergency department.
For real, give me the ER. And even CVICU, it's just 1 or 2 patients. I could pull that off, but my God, 6. Woo, that was I was not thriving. I did my best. I gave good care, but my charting was just so late. So very late.
Oh, that's funny. Thank you for sharing that.
Of course.
What's your preference? Sand or mountains? Either way, Nurse Gwenny's got you covered. We've got flight-ready in-person classes all across the country. Between now and next year, you can choose. Check out the shop page or the classes page on the Nurse Gwenny website and sign up for a class near you or where you'd like to head for vacation. See you there.
All right, walk us through your first case, Sarah, of a rapid response call that never should have happened.
Okay. So this is a case that I didn't get clued into until the afternoon. Like I said, I was very busy in the morning. I didn't get to do anything proactive. But here's what's happening in the patient's room. Okay. So there's this patient that was admitted for like generalized malaise, not feeling good, history of rheumatoid arthritis, so on lots of medications. When I looked back at the chart, the 7 a.m. vitals were a heart rate of 122, blood pressure 102/40, which gives you a map of 61. And again, that would have flagged for the muse. That would have been a muse of 3. That blood pressure and that heart rate would have been a little bit elevated muse. So the nurse got those vital signs. She called the doctor. I think it was a he, actually. He called the doctor. And the doctor ordered metoprolol for the heart rate. Unfortunately, looking back, there was no recheck of the vital signs after giving an IV push of metoprolol until 4 hours later, that's the expectation. A minimum is every 4 hours vital signs are taken on the med-surg floor. So no recheck of the vital signs. Metoprolol was given at 11-ish. Heart rate's now 140. So I don't know if the metoprolol ever helped the heart rate and it just went back up again, or if it just continued to climb. Don't know. And now the blood pressure is 89/38 with a map, I think it's a map of 55. Okay, so at that point, I guess the nurse must have called the doctor again, or maybe the doctor just ordered it themselves. And they ordered a liter of IV fluids for the patient. Okay. And then once again, there's no recheck of vital signs until 1600. And at 1600, the vital signs are heart rate of 144, blood pressure of 80/36, which is a map of 51. It looks like either the nurse called the doctor or the doctor just saw the vital signs and ordered another liter of fluids for the patient. Okay. Busy Sarah finally sits down. I pull the muse at 1700, which I wish I could have pulled it earlier, but this is the first I get to see it. And I saw heart rate of 144, blood pressure 80/36. And I was like, oh my goodness. So I called the nurse. I was like, hey, how's your patient? I see the vital signs are not so good. Like, how can I help? She's like, oh yeah. I saw that. I was just about to call the doctor to see if they wanted to give more metoprolol for the heart rate. But yeah, if you want to come, that's fine. Okay. So again, vital signs were taken at 1600. I didn't pull the muse till 1700. So these vital signs have been existing for an hour with no response to them. So I'm basically like walking as fast as I can to the bedside. And when I got there, I took a new set of vital signs. Now the heart rate's 150, blood pressure is 76/30. Patient is cool to touch and clammy. Like, this patient has deteriorated so severely. And I wish we could have done something about it at 7 a.m. when they first kind of showed us the signs. I don't know that metoprolol was the best intervention for this patient, who turns out they were in septic shock and they're tachycardic because they're trying to compensate and because they have lactic acidosis. Also, wanted to mention, the respiratory rate the entire time was documented as 16 because it's always 16. But no, this patient was breathing like 46 times a minute.
Oh,
and so
goodness.
I know it's heartbreaking, right? And we hear this, we're like, oh, I would never do that. I would never. But if you go back, the initial blood pressure, 102/40, like, it's not the worst ever. And I think that somewhere along the way, someone taught us that if it's greater than 90, everything's fine. But if you look at that pulse pressure, 102/40, my goodness, those blood vessels are dilated for some reason. Like, what is going on here? I don't know that we could ever give enough fluids to fix that blood pressure. That patient definitely is going to need some vasopressors to clamp down the pipes to improve their perfusion. And so it was just heartbreaking to see this case, because you look back, you see 3 sets of vital signs that are worse every time, despite the fact that there were interventions. There was metoprolol given, there was a liter of fluids, there was a second liter of fluids, and vital signs continue to decline, and the patient continued to decline. And so there's so many takeaways from this case, but I think number one, it is that if you see tachycardia, don't reach to just treat the tachycardia. If I see a sinus tachycardia, I'm like, what is the source? This is a symptom of something else. I don't want to just fix this, and I want to figure out why are they tachycardic in the first place. Number two, that widened pulse pressure, that should be a big concern. This patient might be vasodilated. And so of all four fluids, let's start with fluids, right? They're not already fluid overloaded in some way. But if the fluids didn't do nothing, I don't think the fluids is the solution. I mean, you'd be looking at something else. And then there were no further diagnostics done. It was just slap metoprolol on it, slap a liter of fluids on it, slap a liter of fluids on it, but no further blood work or imaging or anything to figure out why is this patient having these vital signs. And while I can't speak to how the patient looked at 7 a.m., at 11 a.m., at 1600, I can tell you how they looked at 1700, and they looked like they were about to die. They, that kind of dusky colored skin,
Yes.
you pull back the
Yeah.
covers and the knees are a little purpley, and patients working to breathe and kind of in and out of consciousness. Again, I don't know when that began because I wasn't there to assess it, but it doesn't usually happen out of nowhere. Usually it's a gradual progression.
Yeah,
And
absolutely.
the beautiful thing I see in some bedside nurses is sometimes they'll tell you, you know what, I know the vital signs are okay, but that's not how they usually breathe. That's not how their skin usually looks. It's something's off. Dude, if we could clue into that, we probably could have caught this guy at 7 a.m. But because it took to me, it was blaringly obvious at 1700, this patient is so close to coding, but it was just missed on so many intervals. So I'm yapping a lot. What are your thoughts, Gwenny? What is your takeaways from this case?
I really appreciate all the points that you made. And my preceptor, when I was a brand new ER nurse a dozen years ago, told me that a blood pressure without a pulse is useless information. Anytime we're looking at a patient's blood pressure, we should also be looking at a pulse. And so I could see how somebody who's maybe new or inexperienced would see a blood pressure of 102 over, the diastolic does really scare me, 102 over 40, was that right? The first one?
Yes.
Might look at that and focus on that systolic of 102 and go, that's just a soft pressure, no big deal. And if I saw a blood pressure of 102 over maybe 50 or 60 in a patient with a heart rate of 70 or 80, and that person was fit and maybe young, that might be normal for them, right? A marathon runner, that's totally normal for them. Very petite female, totally normal. But if I see 102 over 40 and a pulse of 122, I'm thinking to myself, look, I ain't even got to do the math homework about it. I already know that this patient's shock index is greater than 0.9. It's greater than 1 because the top number is bigger than the bottom number, right? So as a reminder, our shock index, if for our listeners, if you've never heard of that, it's just their heart rate divided by systolic blood pressure. And we know that anything below 0.7, totally normal, right as rain, good to go. But anything greater than 0.9 has a high morbidity and mortality and demonstrates an increased likelihood that this patient's going to require resuscitation. So if you're not a mental math kind of person, just know that if the heart rate is anywhere close to or higher than the systolic blood pressure, you are in trouble, and we should look for a reason why. And I love what you said about we were just slapping metoprolol on the heart rate. If we're giving metoprolol, that means that we are assuming that tachycardia is a heart problem, and so we need to treat that with the beta blocker. However, this patient was crying out for help. While they might not have said, hey, excuse me, I'm not feeling so swell, their vital signs were crying out for help, and all three of those cries were missed until someone who could appreciate the indications of what those vital signs mean were able to pick up on it and go, hey, whoa, this is the patient's trying to tell us that they are super duper sick. I think another cool learning point from this case is the importance of our teammates, right? We talk, of course, you and I, we're both nurses. We have podcasts about nursing. We talk about the nurses, and we might not give enough credit to our PCTs, our patient care techs, or our CNAs, whatever you call them at your various shops. They are such an important part of the team. You know, when I'm working in the emergency department, generally, I only have 3 patients at a time. And if I've got somebody that's pretty sick, and I might be spending more time, maybe I'm titrating a cardine drip so I can't leave the bedside for, quite a while, or I'm giving blood, so I'm camped out for at least the first 15 minutes at the bedside. But I'm relying on my teammates to keep an eye on my other patients. And sometimes it's my patient care tech that might go in and see a patient and come back to me and say, hey, Gwenny, that guy that we put in room 19 an hour ago, he's not looking so great. And over here on the monitor, his vital signs are doing XYZ. And I rely on those teammates. They're such a valuable part of our team. And so for these med-surg nurses who have 6 to 8 patients each, and the techs are in there delivering the lunch trays and checking a glucose and, cleaning the rooms, emptying the trash, things like that. They are in there with more frequency than the nurses are a lot of times. And so we really can rely on them to speak to maybe some changes and trends that are going on for our patients. So if you're listening to this and you're a tech, please realize you are such an important part of our team.
Absolutely.
Do you see?
I can't tell you times that I go, I go to emergencies all the time, and I ask the nurse, like, what's this patient's baseline? And the nurse understandably says, this is my first day with them, so I don't actually know. And the nurse texts like, oh, I've had them for 3 days. This is my 3rd day with them. And let me tell you, this is not how Mr. Johnson usually is. Usually he's very talkative. He was just telling about his grandkids yesterday. So like the nurse tech's input and assessment and like overall, just thought about this patient, I trust it all the way. Like they have so much insight into these patients, like you said, because they've spent so much time doing patient care, feeding a patient, helping a patient, go to the restroom. You learn so much about how they are, and you can pick up on those alterations whenever things just aren't the same. So I can't echo that enough.
So what was the outcome on this patient? I'm assuming they got moved up to step down or maybe even ICU.
ICU, yeah. At this point, so at my hospital, when you call a rapid response, like an official activation of the team, you get a rapid response nurse and a critical care provider of some sort, nurse practitioner, PA, or the ICU resident. And so as a nurse, I could not order norepinephrine for this patient. And I was pretty sure that's what they're going to need. So I called a rapid response. I know I'm the rapid response nurse. So I'm basically like activating myself, but alongside me would be the respiratory therapist and the ICU provider. So they came to the bedside. We got vasopressor started, got the blood pressure a little bit better. She actually did perk up a little bit once we got better perfusion to her brain. We went to the ICU, septic shock, ended up going to ARDS. I mean, the patient was in the ICU for weeks because they declined so severely. You know, when your blood pressure is that low for so long, multiple organ systems take a hit. And so, especially the kidneys, those girls are so sensitive. And so
I
if
call
they
them
have
princesses.
they have a couple low blood pressures, they're like, yeah, we don't think we can do it anymore. I think we need to take a little vacation. And so they were down for the count for a bit. Patient had to go on CRRT, like just so many things evolve because this blood pressure, this perfusion issue wasn't addressed early on. So I think the big takeaway here is that we have the opportunity and privilege to be the voice for patients that can't speak for themselves. And if we get so caught up in the task of nursing, and I get it, there's so many, I got to test the medication and document it and send the blood and make this folk, like there's so many tasks. It's easy to get caught up in the task, but if we can just take a moment to look past the task and see the human in front of us and say, okay, what's happening with them? How can I promote their best outcome? Are there any changes that I need to be speaking up and saying something about to advocate for what their needs are? How can I do that for this patient? That kind of helps us get past the task of, low blood pressure, fluids, high heart rate, meds. And it's not all just like task response, but like dig a little deeper, pull back the covers, assess your patient, touch their skin, look at their mental status, and kind of be that voice to the whole team to say, there's been some changes here. We need to stop just slapping a little Band-Aid on. Like, can we do some further investigation? What's happening to my patient? They are different. And I think that what an opportunity we have to be that voice for our patients.
Yeah, excellent. Well, that's a really good example of a rapid response case that should never have happened because it should not have gotten that far, right? It should have been caught earlier in the day before we had 8 hours of sustained damage to the kidneys through a pre-renal injury of hypoperfusion. So what's another case, maybe a different set of circumstances, a rapid response case that should never have happened?
Okay. So this was a case that there was like the Swiss cheese model, where multiple things happened that probably shouldn't have happened. They all seemed very minor and they ended up to be a really bad patient.
Yeah.
Okay. So the day shift nurse, God bless her, she agreed to stay till 11 p.m. because night shift was short staffed. So she's working a 16-hour shift. And the plan was at 11 p.m., she's just going to pass off her 6 patients, 1 to each other nurse on the floor. So everyone just gets 1 additional patient, right? Okay, so it's 11 p.m. she does hand off to all those other people at 11 p.m. One of her patients in particular was just a simple ortho procedure. Patient had been very stable all day long. Patient was sleeping. So rather than doing a bedside shift report, the nurse just went to the nurse taking the patient 11. Again, she's tired, 16 hours. Hey, this patient's ortho, blah, blah, blah. They didn't actually go in the patient's room to assess the patient like you're supposed to do at bedside shift report, or to greet the patient, or let them know, hey, I'm handing off shift to this next person. They just let the patient keep sleeping. And then no one actually assessed this patient. Reasonable, but frowned upon. Because there should always be a bedside shift report. I mean, there's so much evidence to support it. There are very few circumstances where it's in the patient's best interest to do shift report at the nurse's station. Very few circumstances. And this is not one of them. I mean, it's not that big of a deal to wake a patient up just for a second and say, hey there, how you doing? I'm heading home. This is Allison or whatever. This is the nurse that's taking over. That's not the nurse's name. This nurse taking over. You doing okay? You need anything? Okay, I'm heading out. Have a good night. It takes a second, right? I think the patients don't mind it, but that did not happen in this case. Okay. So the nurse was like, yeah, patient's been stable, they're fine. There's no meds due until 6 a.m., so it should be a fine night for you. Okay. So the patient slept all night long, slept in quotes. And then at 6 a.m., the nurse who had received this extra patient went in to give the morning medication, and the patient really wasn't arousing. And she's like, you know what? The patient needs some sleep. I'm just going to let him keep sleeping. So just documented they can give this 6 a.m. medication with the morning med pass at 8 or 9 or whatever. So didn't actually pass the medication. So then the next shift comes on, day shift the next day. And again, they proceeded to not do bedside shift report, did not go in the patient's room. So there was this critical illness brewing, which you're about to find out about, that no one knew, because vital signs haven't been taken, because this floor, they actually don't do vital signs after whatever time. They let them sleep until the 7 a.m. vital signs. Again, this is ortho patients. They're super duper stable for the most part. Let them recover. They need their rest. Okay.
I'm so scared you're going to say fat embolism syndrome. I'm scared that's where this is going. I'm bracing myself. Okay, go ahead.
Okay. So, patients is snoozing. Can you guess who finally caught this patient's decline? We were kind of just talking
based
about
on the
value of this
conversation
team
we just
member.
had. I'm going to guess our patient care tech.
Patient care tech, nailed it. So the patient care tech goes in the patient's room to take the morning vital signs. They actually knew the patient from the day before. So the patient wasn't arousing. They're like, that's weird. This patient was just yapping yesterday. Hey, wake up. Good morning. It's time for vital signs. How are you? Patient's not arousing. So the nurse tech quickly goes and gets the nurse. It's like, hey, this patient's very different. I'm super concerned. They're not waking up. The nurse tech themselves calls a rapid response. And that's when my team got activated. So I actually was not the nurse on this case. I went to the RCA, which is why I'm familiar with the case. RCA is root cause analysis. So when catastrophic events happen, the hospital wants to kind of dig down into what happened in this case. Okay, rapid response comes. My nurse pulls back the pupils and they're blown. Took the patient to MRI, or CAT scan first, but ultimately MRI determined this patient had a brain bleed that's probably 9 or 10 hours old.
Oh,
So most likely this patient started having a brain bleed maybe 10 o'clock or so. But again, they were sleeping, didn't want to wake up to assess the patient. And this patient's brain bleed just evolved all night long, sleeping through it as far as the team was aware. And ultimately, unfortunately, this patient died from the brain bleed.
Oh my goodness.
Now, I recognize that the prognosis for any patient with a brain bleed is poor. However, patients who have brain bleeds that we catch early on, we can often get a ventriculostomy in and salvage that brain tissue. Very often, the patients that die are the ones that are at their house and no one sees that they're, had this event happen. But when it happens in the hospital, we should be able to do something about it.
Yeah.
And so the fact that this patient had a brain bleed on our watch and nobody caught it, it breaks my heart so much. And, from a nursing perspective, I understand how busy it is. You work 16 hours and want to go home too, but it just kind of reinforces the value of doing a quality handoff at shift report, going to the patient's room. This is the patient I've been caring for. I want you to know this is what they look like, because if there's any changes, this nurse who's been knowing the patient all day long, she's like, well, hold on, this is actually very different than how they usually are. We need to do something about this, right? There's so much
Yeah.
value in bedside shift report. And I think that it's been sold to us as like, oh yeah, bedside shift report is good for like patient satisfaction scores. Of course it is. That's actually not my biggest motivator. My motivator is safety. I want to make sure that the patient I'm passing off is the patient I've been caring for all day long and not something else that's so like for my own license sake, here's the patient I've been caring for. They're in your hands now, right? And then for the receiving nurse, I want to know like, there are any changes where I take those patients? It's just, there's so much value in bedside shift report. Again, it was sold to us as like patient satisfaction scores. That's not actually the reason why it's great. The literature shows it's great for patient safety. And I feel like in this case, bedside shift report might have been able to catch it. But kudos to the nurse tech who recognized the patient was declining and spoke up and advocating up the team going for the patient. But unfortunately, in this case, it was way too late.
I think this is a good case to remind ourselves of the concept of normalization of deviance. So if you've never heard of normalization of deviance, right, we know that due north, just for our example here, is our safe direction of travel. So for this, we know that bedside shift report is what's safest for our patients and sets us up for success as nurses, 2 sets of eyes on the patient at the same time so that we make sure what the nurse is telling me jives with what I'm seeing, right? We know that that is the most safe way to do it, right? But if we accidentally get away from that, maybe not accidentally, but we do something like, it's reasonable. The patient was sleeping. We don't want to wake her up. That's just slightly different than normal, right? It's not like we were like, oh, we hate bedside report. We refuse to do it. It's just a slight deviation, right? In that we're saying, well, we normally do, but just this once, we're gonna not do bedside because it's 11 o'clock at night. The patient is tired from having surgery today. We're just gonna let her sleep. But what happens the next time you come? If nothing bad would have happened, this time it blew up in their faces, right? And so, but what happens next time? Well, we didn't do bedside report last time, and nothing bad happened. So this time, I'm just tired. I just don't want to walk all the way to the room. It was a really busy shift, and so we skip it for a different reason. And then with enough tiny deviations, now we're traveling in a totally perpendicular from safe direction operational procedures, right? Instead of it being the norm that we are doing bedside report, now the norm is that we're never doing it. And so with just a slight deviation from normal, you might not notice a big change. But if you deviate enough times, it's not a matter of if it's harmful, as when it's going to blow up in our faces. So let that be a reminder that if you find yourself drifting from the normal practice, like, oh, I'm in a really big hurry, I need to push this med, I'm not going to scrub the hub this time. No, I'm going to scrub the hub every single time because it might not result in something bad happening the first, second, or 150th time, but maybe it's the 151st time that I do this unsafe practice that it's going to impact a patient. So just remember to just keep doing the right things that we know, the safe things to do. Remember to wash your hands before going into a patient room. Remember to do your bedside report. Remember to scrub the hub every time we push a medication.
Are you studying for your certified emergency nurse exam? Nurse Gwenny's got your back. Her latest book, a CEN test prep book, is just what you need. Find it at nursegwenny.com.
So Sarah, thank you so much for sharing these 2 cases of rapid response calls that never should have happened. I think it gave us some good reminders about what we can do to prevent these emergencies, whether you are a floor nurse, an ICU nurse, an ER nurse. I think these lessons are applicable to us everywhere. Close us out. Is there anything else that you want us to know that we could learn from these cases today?
I think generally speaking, there is something valuable about like presence, like being with your patient. And with time, you learn to correlate like the clinical data with what your gut is saying about the person. And so often, I'll see, say, vital signs on a screen, like, oh, those are fine. But then I come be with the patient, like, oh, okay, no, this is not fine. And vice versa. I have on the patient, they look okay. I see the vital signs, like, oh my goodness, okay, that I didn't realize they were so tachycardic. They actually were masking that pretty well. We had to correlate the 2 together. And so as a nurse, I would say if you feel that gut instinct something's up with your patient, but your vital signs are still looking pretty, lean into it. okay, what could it be? What can I rule out? What could be going on? In my mind, and maybe this is bad, I'm always thinking worst case scenario. Like every patient that I encounter, maybe that's because I just see lots of worst case scenarios in my particular role. I am always thinking worst case scenario. And I feel like so many nurses are like, they just always assume things are going to be fine because they're used to patients that are getting better and improving and being discharged. But in my world, they always get worse. And so I'm constantly thinking, like, I'm looking for the zebras. Like, do they have septic emboli to the brain? Like, did they, like, I'm just crazy. So I'm trying to figure out what could this possibly be that would cause this patient to have this alteration. So anytime a patient is ultramental status, what's going on? Could it be something minor, like they haven't slept enough? Okay, maybe. Could it be something serious, like septic emboli to the brain? Maybe. No, until I dig a little bit further. So I think that we have the responsibility, the amazing responsibility, to lean in. If our gut system up, lean in, figure out what's going on. And if you can't figure it out what you've been given, then ask for more diagnostics. Doctor, how would you feel about doing an ABG on my patient? They are breathing really fast. I don't know what their metabolic status is. We had a patient just yesterday that was tachypnic, and we got the ABG back, and the pH was 7.1. I was like, whoa.
Oh my gosh.
Lactic acid was 12. Like, okay. Honestly, aside from tachypnia, their vital signs were not that bad. And so, just if you see something doesn't feel right, why is the patient breathing fast? Why is their mental status different? Why is your skin cool all of a sudden? Why is their belly looking bigger? Why are their eyes look glazed over? Like all these little things. Why? And if you don't have an obvious answer, then dig deeper for what it is. That is our job. That is our calling. Our amazing responsibility as nurses is to speak up for our patients when they can't speak for themselves. So that would be my summary.
100%. Building on that, my least favorite assignment when I'm working in the emergency department is triage. I don't like it because it seems like, now the goal in triage is to identify which patients are the sickest and need to be seen first, right? That's the purpose. However, it feels like the purpose is to move as quickly as possible because it's like herding cattle, as fast as they can come through. And at the particular ER where I was working recently, the computer that the nurse had to sit at was a desktop computer. It wasn't on a mobile, station or anything. And the chair where the patient sat was behind it. So I said 1,000 times a day, the patients would come in and they would sit down there. And I would always say, I would turn my chair away from them, and I can't type and be in that position at the same time. And I would say to the patient, like, hey, I'm really sorry my back is to you right now. This computer doesn't move, but I just want to take a second, introduce myself and look at you with my eyeballs, right? I want to see the patient and I got to stop and turn away from my task of trying to type in everybody's information. And I found that it was detrimental that a lot of nurses were just trying to go as fast as possible because you've got ambulances bringing your patients and then more patients coming in through the front door. And it's, I got to get these patients triaged within X number of minutes or I get my hand slapped, and you just feel like you're drowning in triage. And so pausing, taking a moment and spinning and looking at your patient, you're going to see things that you would not have noticed. You were talking about that tachycardic patient that they looked just fine. But then when you look at the vital signs, oh my gosh. Now, oppositely, there are patients who have normal vital signs, but when you look at them, you're like, no way. I don't believe that. Something's going on here.
You're
right?
compensating too good right now, buddy, because you're terrible.
Yeah. So all those small little lessons, and those are things that I didn't appreciate when I was a new nurse. I didn't know how to see a blood pressure of 102, and I just thought, oh, that's a soft blood pressure, no big deal. I didn't know how to pair it with tachycardia because even a mild tachycardia of like 110, that's barely above normal, no big deal, right? But when I compare those two things, mild tachycardia with a soft blood pressure, now as an experienced nurse, I know that that's a shock index of greater than 1. And that is wildly concerning. And so if you're a newer nurse listening to this, don't be discouraged, but just watch what your mentors are doing. Watch what the nurse who's been doing this for 35 years and how he or she can appreciate those subtle changes as warning signs that your patient isn't as great as maybe you might have thought they're doing.
Amen.
Sarah, one way that I like to close out on my podcast Tell me something that you are proud of yourself for having done recently. Doesn't have to do with nursing. Can be anything. What's something you're proud of yourself for?
Man, put me on the spot. Okay, so this seems silly, but I recently flew out to speak at a conference, and when I got there, I realized that the conference center had this amazing pool, and I had no intention of like going swimming. I was gonna get to the conference, get to the hotel, study my talk, and then just go to bed. Be a responsible adult. I got there, and I was like, oh my gosh, this pool, there's like just a lazy river at this hotel. Like, this place is
Ooh.
fancy, and I was like, you know what? I'm going to the gift shop, and I bought myself a bathing suit, and I went to the pool, and I had dinner by the pool by myself, and I just enjoyed an evening to myself to like recharge and recuperate. And it was a different kind of preparation for my speech the next day. But I feel like it was so good for the soul, and I'm proud of myself for like taking a moment for me and not just being so like responsible all the time, but doing something that was life-giving as well. So yes, that's what I did this past weekend is I sat by the pool by myself.
I
And ate
love
snacks.
it.
Yeah, it's great.
I am proud of you for honoring yourself as well, because a lot of times us busy ladies, as high producers, right? We
Mhm.
prioritize work and we hush our own wants or desires of, oh, it might be fun to sit by the pool. No, must do work. But you took a second and you honored that within yourself. And I bet that you did even better studying and retaining the information as you're reviewing your presentation, because your body was more relaxed. I used to have a therapist that would tell me, Gwenny, stress can't live in a relaxed body. And so he taught me the prioritization of making sure I'm doing my yoga and going for walks, because that helps our mind when we care for our body too. So good job. I'm proud of you too. And Sarah, thank you so much for sharing your morning with us here on the Nurse Gwenny Podcast. And be sure to check out the Nurse Gwenny Library. And actually, Sarah has a discount coupon that you could use to save some money on the Nurse Gwenny Library. And your code is? Hey, it's okay.
Those.
Thank you
Okay.
so much for your
Thank you,
time today.
Ray. So it
Yeah.
was so good to see you too.
Yeah, this was really good. There were so many pearls from this. Like, I knew there would be a lot, but I didn't think there would be this many. So
No, yeah, so
excellent
many.
job.
All right, thanks, friend.
Thanks for listening to the Nurse Gwenny Podcast. If you want to earn continuing education credits for this episode and much more, head on over to the Nurse Gwenny Library, where learning is fun and nerds aren't cool, at www.nursegwenny.com, where your subscription gets you access to long-form content like my critical care prep course, Light Ready, podcasts, clusters of micro-learning, and so much more. Remember to be kind to others, be kind to yourself, and always keep learning.
All right, that's it. Thank you so much for listening. And now go subscribe to Gwenny's podcast yourself. Oh, and in the interview, she asked me what my coupon code was, and I couldn't remember it. I should have. It's pretty easy. But if you'd like to join the Nurse Gwenny Library and get CEs for the episode you just listened to and so many more, you can use the code Rapid Response RN. All word. All one word. All right. Thanks guys for listening. Have a good one.